She um, she's 71 years old now. She's been diabetic for at least 15 years. Very well motivated, well informed, up on what's happening, takes care of herself. She keeps a blood sugar log that she made up a form for herself, that she uses. That's very easy to tell what time of day it is, what her sugar is, everything like this. So anyway, when she first became diabetic, we tried to start with metformin. She got hives. We tried it again. She got hives again. So, I mean, she is well and truly allergic. Um, she's hypertensive, hyperlipidemia, obesity. She had coccidioidomycosis about 6 years ago. And since then, she has had an elevated red blood cell count. For a while, she had very high red blood cell turnover, and it was hard to tell what her A1C was actually doing. We followed fructosamines during that time, but now her A1C and her sugars seem to be more on the same page. She then developed a thyroid tumor, and now has post-op hypothyroidism. Um, Her last A1C was 6.7, so she's not badly controlled on what we're doing. But her BMI is 44, and she's just very frustrated because she has been unable to lose weight. And the weight is really the only remarkable thing about her physical exam. Her labs, her renal function has been normal. Her TSH is maybe a little higher than we might like it, but her free T4 has been normal. She's had a normal diabetic urine. Her hemoglobin and hematocrit always stay a little bit elevated since she had this fungal infection. We sent her to hematology, and they basically kind of said, yeah, that's how it's going to be. So her medications are there. She's on Tresiba 80 units a day. She's on the Naglindide and empagliflozin. Yeah, I was tongue-tied here. She's also on furosemide, losartan, metoprolol, nifedipine. Her blood pressure's been a little hard to control, but it actually is controlled on this regimen. She's on low-dose rosuvastatin because that's what she's tolerated, and her thyroid has never been terribly out of whack. She's on her levothyroxine. She takes a vitamin D supplement. So our questions really are whether we could do something with her diabetes therapy that might make it easier for her to lose weight. Are we keeping the weight on her with the insulin? And now that she's had the thyroidectomy, could we try the GLP-1? She has been very, very reluctant to consider it, even though the type of thyroid tumor she had isn't necessarily the ones that are caused by these medications. So that's where we are.
Thank you so much, Dr. Redstrode. Great case presentation as always. Before we jump into any of the feedback and recommendations, did anyone have any clarifying questions for Dr. Redstrode? Feel free to unmute, chat in. All right, and any of the hub members with any recommendations, feedback?
Can I add one thing? She was on Victoza when she developed that thyroid tumor, which has been another reason she's reluctant to consider something else.
Thank you for adding that. And I'm happy to pull up the case as well. Dr. Giordano?
Yeah, I would start by saying thyroid nodules are very common. And so it is important to know the type of nodule that she had histologically. When we think about prescribing GLP-1 receptor agonists, the biggest concern is if the patient has a history of medullary thyroid cancer, then we avoid the drug. I will tell you that medullary thyroid cancer is incredibly rare. Most commonly, when people do have thyroid cancer, it's typically papillary and then follicular. Only about 1 to 2% of all thyroid cancer cases are medullary thyroid cancer. I also want to point out, and hopefully this reassures you and the patient, that the studies that were done in GLP-1 receptor agonist therapy that had that linkage to medullary thyroid cancer, that was done in rodent studies. It was not done in human studies or shown in human studies to have a link between the GLP-1 receptor agonists and medullary thyroid cancer. And so I feel very comfortable prescribing them in patients with thyroid nodules. I typically don't order an ultrasound. I'll ask them if they have a personal or family history of medullary thyroid cancer. But again, that's 1%, 1 to 2% of all comers with thyroid cancer. That's a very, very rare occurrence in it of itself. And then when we think about, benefits and risks of any drug, when you're thinking about writing a GLP-1 receptor agonist, the benefits are tremendous in diabetic patients, right? In my opinion, it in the next 5 years is going to overcome Metformin as a first line drug. And it should be, because it's the only drug that has primary and secondary cardiovascular prevention in all of our therapy. So I think when we continually say Metformin is first line, it is my clinical opinion that that's outdated. I don't feel that Metformin should be first line. I think because it is cheap and available, it's accessible for patients. But when we think about, the primary and secondary prevention in terms of cardiovascular disease, all of our diabetics should be on that to prevent cardiovascular disease or strokes, right? And so I highly recommend that she tries a GLP-1 receptor agonist. I think it is important to get the pathology of that resection and make sure that there was no medullary thyroid cancer detected. But I would recommend that to her. I think she would greatly benefit from it because her BMI is 44 and she would have A1C lowering, she would have weight loss lowering, and it would be primary prevention for cardiovascular disease. It seems as though her regimen, she has a pretty high injection burden, so I think that's another way to approach it too. If you went on Ozempic or Trulicity, that's a once a week injection as opposed, to some of the other like insulin or the, post-meal agents. So I think that that's another angle you could approach it from. Mm-hmm. If she's broken out in hives, consider there's a drug called Riomet. It's liquid metformin. So sometimes when patients have hives and allergies to medicine, always consider that it may be the fillers that we're making the medicine with, as opposed to the actual drug itself, so maybe it's one of.
Oh, Dr. Giordano, I think you're muted.
Oh, sorry. So can you guys hear me considering Riomet? Yeah, yes. So Riomet is just liquid metformin, and you could attempt that. It's harder to get, not always covered, but you could make sure to document, broke out in hives twice after trying metformin, and see if you could do Riomet with her. That's just, like I said, liquid metformin. Because you have felt her A1C may not be accurate over time, you could certainly do a continuous glucose monitor in her. Insurance companies don't really like to pay for CGMs because they're expensive. It's a real burden to try to get them covered. But in someone who has an inaccurate A1C because of, anemias, kidney disease, I highly recommend either, finger sticks with a meter or a continuous glucose monitor. If insurance doesn't cover it, the most current price that I've heard for like the Libre is about $65 for the reader. You don't necessarily need the reader. If you have a smartphone, you can download the app. And then the portion that sits on your arm is called a sensor. It's changed out every 2 weeks. That's about $65 for 2 sensors a month. So that's a pretty steep price still. But if she's willing to do that, that'd be another way to monitor her sugars. If you're not convinced that her A1C is truly accurate fructosamine is a great way to monitor it. Fructosamine is just the amount of sugar that's bound to the albumin or protein levels in your blood system. So I think that that's also fine to continue doing the fructosamine. Ultimately, I think your goal of getting her on a GLP-1 is a great one, because you could lower her amount of insulin, which will also help her weight loss. Insulin is a great drug, but can cause fluid retention and weight gain. So I think a GLP-1 receptor agonist is great from a multitude of angles.
Okay. We do have that pathology. It was a Hurley cell tumor.
Okay, so that's certainly not medullary thyroid cancer. That's a benign finding. And so I would not order the GLP-1 receptor agonist with that pathology. I would tell her that it is safe in this pathology to continue with the GLP-1 receptor agonist.
Yeah. Yeah, and we've thought about we have some samples here actually of some of the CGMs, and we've thought about doing a study or a Libre Pro study, just to see, if we could get more information. Although like I say, over the last 2 years, probably I have felt like her A1Cs have been more in line with what we're seeing, based on the meticulous records that she is keeping. So I think that, but yeah, so it sounds like I can, kind of change the talk, and I'll probably take your name in vain there, Dr. Giordano, as having talked to you about using the GLP-1 agonist.
That's what I'm here for. Blame it on me.
Yeah. So
always blame it on me. Say, we had this discussion and we really feel like it would benefit her tremendously. And if she feels more comfortable doing an ultrasound of her thyroid in 6 months, or, coming in for a neck exam in 6 months to a year, that may be something that you could offer to kind of reassure her. But yeah, please tell her you spoke with me, and I agree with your plan. It's a great one.
Yeah, well, we'll see what we can do.
Thank you so much, Dr. Giordano, for all that feedback. And thank you again, Dr. Rexter, for that case. Did anyone have any other feedback, recommendations, or comments?
Just to follow up, I completely agree that as a class, the medications are safe to use in this patient. If she's really concerned, Byetta, exenatide, and lixisenatide were not shown to have that increased risk of medullary thyroid cancer, even in the rodent studies. Lixisenatide is only available in the combination with Celeco in the United States, and with the amount of insulin she's taking, I don't think it'd be appropriate for her because it's a 60 unit per injection max. But the Byetta, the exenatide, it would be a daily injection as opposed to the weekly injections like Ozempic or Trulicity. But if she's more concerned about the thyroid cancer risk, those were never shown, but it would be a daily injection. So maybe she'd be more comfortable with that option. And then just to follow up with like the first line therapies that Dr. Giordano was talking about, the ADA just released their newest guidelines yesterday, actually, and they changed the wording of the first line therapy to say it generally includes metformin and lifestyle modifications. So I think that's already starting to open up the window for us to be considering SGLT2s and GLP-1s as possible first line options. It's no longer just listed as metformin is first line, it's just generally includes metformin and for, lifestyle modifications.
That's very interesting. Thanks for adding that, Hugh. We really appreciate it.
Thank you, Dr. Quinn.
Woohoo! We're all in the holiday cheer. I'm so excited for Christmas. Anyways, anyone else have any comments, feedback, recommendations, anything they wanted to add? And Dr. Rextra, did you have any other questions about your case?
I don't think so. I mean, I think this is, the sort of discussion I was hoping for, that, to hear what you guys would do in this situation. So I think I'm hearing you loud and clear. So
Awesome. That's great to hear. And if you do ever have any questions after the fact, just send us an email and we'll send it over to the hub members. So alrighty, well, thank you all so much. Thank you, Dr. Rexford, for the case. We'll go on to the didactic portion. Let's see. So Kylene, anytime you're ready, I'll pull up your didactic for you and just turn things over to you. I know you had another PDF resource that you had sent me, so anytime you want me to pull that up, I'm happy to as well.
Okay. How do I advance the slides or do you do it?
So I'll do it on my end. Just let me know when
Okay.
you'd like to go to the next.
Okay. All right. So I'll be presenting on the ADA guidelines in the older adult population. So we can go to the next slide. Prevalence. So diabetes is a highly prevalent health condition in the aging population. Over a quarter of people over the age of 65 have diabetes, and half of older adults have pre-diabetes. And a number of adults living with these conditions is expected to increase rapidly in the coming decades. The next slide. So screening, you want to obviously screen your patients for diabetes in general periodically, but we also need to be screening for other geriatric syndromes like polypharmacy, cognitive impairment, depression, urinary incontinence, falls, and persistent pain in older adults. Older adults with diabetes are at greater risk for these syndromes than other older adults, and these could potentially affect diabetes self-management and diminish their quality of life. And next slide. Cognitive impairment in older adults. Screening for early detection of mild cognitive impairment or dementia should be performed for adults 65 years of age or older at the initial visit and then annually as appropriate. The presence of cognitive impairment can make it challenging for clinicians to help their patients reach individualized glycemic, blood pressure, and lipid targets. It also hinders their ability to appropriately maintain the timing of meals and the content of their diet. It is crucial to simplify their drug regimens and to facilitate and engage the appropriate support structures to assist the patient in all aspects of their care. Next slide. Screening for cognitive impairment should additionally be considered when a patient presents with a decline in their clinical status, like if they're having errors calculating insulin doses, difficulty counting carbs, skipping meals, skipping insulin doses, difficulty recognizing, preventing, or treating hypoglycemia. And next slide. And then a big factor with older adults is hypoglycemia. Because older adults with diabetes have a greater risk of hypoglycemia than younger adults, episodes of hypoglycemia should be recognized and addressed at routine visits. For older adults with type 1 diabetes, continuous glucose monitoring should be considered to reduce hypoglycemia. You can also consider them for type 2 diabetes as well. I 100% love CGMs and try to get as many patients on them. And next slide. And cognitive decline has been associated with increased risk of hypoglycemia, and conversely, severe hypoglycemia has been linked to increased risk of dementia. An important step to mitigating hypoglycemia risk is to determine whether the patient is skipping meals or repeating doses of their medications. Unfortunately, they forget a lot of times. Glycemic targets and pharmacologic regimens may need to be adjusted to minimize the occurrence of hypoglycemic events. Next slide. In the Wisdom trial, patients over 60 years of age with type 1 diabetes were randomized to CGM or finger stick blood sugars. And over 6 months, the use of CGM resulted in a small but statistically significant reduction in time spent with hypoglycemia compared with routine finger sticks. While the current evidence base for older adults is primarily type 1 diabetes, CGM may be an option for older adults with type 2 diabetes if they're using multiple daily injections of insulin. And next slide. Treatment goals. Older adults who are otherwise healthy with few coexisting chronic illnesses and intact cognitive function and functional status should have a lower glycemic goal, like an A1C less than 7 to 7.5. While those with multiple coexisting chronic illnesses, cognitive impairment, or functional dependence should have less stringent glycemic goals, like an A1C around 8 to 8.5%. Glycemic goals for some older adults might reasonably be relaxed as part of individualized care, but hyperglycemia leading to symptoms or risks of acute hyperglycemia complications like dehydration, poor wound healing, HHS should be avoided in all patients. And next slide. And this is kind of just a chart of what I just talked about. Healthy patients with very little coexisting conditions typically have a longer life expectancy, so their goal is going to be lower. You want their fasting and preprandial glucose and their bedtime glucose and their A1C to all be a little bit tighter. As patients become more ill with other conditions, you relax those goals some. A lot of times in my older patients, especially patients over 80, I kind of make it the same as their age as their goal. Like if they were 81, I make their goal 8.1. And if they can get it lower, that's great. But I'd rather them prevent hypoglycemia as the number one thing. Next slide, please. A1C is used as a standard biomarker for glycemic control in all patients with diabetes, but may have limitations in patients who have medical conditions that impact their red blood cell turnover. CKD, blood transfusions, hemodialysis, things like that can falsely increase or decrease in A1C. In these instances, finger sticks or CGMs should be used for goal setting. Next slide. Lifestyle management is always recommended. So optimal nutrition and protein intake is recommended for older adults. Regular exercise, including aerobic activity, weight-bearing exercise, and or resistance training should be encouraged if they can safely engage in these activities. So for older adults with type 2 diabetes, overweight and obesity, and capacity to safely exercise, an intensive lifestyle intervention focused on dietary changes, physical activity, and modest weight loss, about 5 to 7% should be considered for its benefits on quality of life, mobility, physical functioning, and cardiometabolic risk factor control. Next slide. And pharmacologic therapy. So in older adults with type 2 diabetes and increased risk of hypoglycemia, medication classes with low risk of hypoglycemia are preferred. Overtreatment of diabetes is common in older adults and should be avoided. Simplifying their complex regimens is recommended to reduce the risk of hypoglycemia and polypharmacy. Consider costs of care and insurance coverage rules as well when developing treatment plans, because if the patient can't afford it, they aren't going to take it. Next slide, please. So on to some of the different medications. So metformin is considered first-line agent for older adults with type 2 diabetes. It's safe in people with a GFR of greater than 30. There are some dose adjustments. So I think 45 you start dose adjusting if I'm not mistaken. It is contraindicated in patients with advanced renal insufficiency and should be used with caution in patients with impaired hepatic function or congestive heart failure because there's a risk of lactic acidosis. Metformin can be held during hospitalizations, acute illnesses, anything that may compromise the renal or liver function. And metformin can cause GI side effects and reduction in appetite. So unfortunately, that can be problematic for some older adults. Next slide. And then there's the TZDs. So Actos and Avandia are the two in that class. If these are going to be used at all, they should be used very cautiously in patients, especially patients on insulin or patients at risk for CHF, osteoporosis, falls or fractures, and or macular edema. Next slide, please. Sulfonylureas. So sulfonylureas and other insulin secretagogues are associated with hypoglycemia and should be used with caution. I typically try to get anyone over the age of 70 off of these medications because of the risk of hypoglycemia. So if they have to be used, sulfonylureas with a shorter duration of action, like glipizide or glimepiride, are preferred. Glyburide is a longer acting sulfonylurea and should be avoided in older patients. But if at all possible, I would avoid all of them. Next slide, please. And then we'll go into the incretin-based therapies. So DPP4 inhibitors. These are oral medications. They have very few side effects and minimal risk of hypoglycemia. The big problem with them is that their cost might be a barrier for some older patients, depending on insurance coverage. The DPP4 inhibitors do not increase major or adverse cardiovascular outcomes. The next slide. There's GLP-1 receptor agonists, which we just talked about those in the case study. GLP-1 receptor agonists have demonstrated cardiovascular benefits among patients with established atherosclerotic cardiovascular disease. These drugs are injectable agents with the exception of the oral semaglutide. But because they're injectable, they require visual, motor, and cognitive skills for appropriate administration. Most of them are once a week, which is kind of a nice thing for patients. They don't have to remember daily or multiple times a day. And GLP-1 receptor agonists may be associated with some side effects like nausea, vomiting, and diarrhea. So they may not be preferred in older adults if they're experiencing some unexplained weight loss. Next slide, please. Oh, I don't think I said that GLP-1s typically don't have a high hypoglycemia rate. And then we'll talk about SGLP2 inhibitors. These are administered orally, which may be convenient for older adults with diabetes. In patients with established atherosclerotic cardiovascular disease, these agents have shown cardiovascular benefits. This class has also been found to be beneficial for patients with heart failure and to slow the progression of CKD. So side effects, unfortunately, can be volume depletion because they act to help you pee out sugar. So unfortunately, people can become volume depleted if they're not staying hydrated enough. There's also a side effect of DKA for some patients as well. Next slide, please. And then insulin therapy. The use of insulin therapy requires that patients or their caregivers have good visual and motor skills and cognitive ability. Insulin doses should be titrated to meet their individualized glycemic targets, but also avoid hypoglycemia. Once daily basal injection therapy is associated with minimal side effects and may be a reasonable option in many older patients. Multiple daily injections may be too complex for older patients with advanced diabetes complications, life-limiting coexisting chronic illnesses, or a limited functional status. And next slide, please. So I've had this sent in a bigger page too, but basically this is just a simplification of the complex insulin therapy regimen. So basically it tells you how you can minimize basal insulin, minimize or get rid of altogether prandial insulin, and different ways to adjust. So I kind of sent this as just a separate thing. The biggest thing is to make sure patients aren't doing rapid or short-acting insulins before bedtime because they have the risk of going low overnight. A lot of my older adult patients, I don't put on sliding scales because it's too complex and too complicated for them. Next slide, please. Special considerations for older adults with type 1 diabetes. So due in part to the success of modern diabetes management, patients with type 1 diabetes are living much longer. And the population of these patients over 65 years of age is growing. This population has unique challenges and require distinct treatment considerations. With type 1 diabetes, insulin is an essential life-preserving therapy for these people, unlike those patients with type 2 diabetes. So to avoid DKA, older adults with type 1 diabetes need some form of basal insulin, even when they're unable to eat meals or are vomiting or anything like that. Insulin may be delivered through an insulin pump or injections. CGM is approved for use by Medicare and can play a critical role in improving A1C, reducing glycemic variability, and reducing risk of hypoglycemia. And I think that's the end.
Thank you so much, Kylie. I know this was your first ECHO presentation, so I just want to give you a big shout out. That was awesome, and we really appreciate your time. sharing your expertise with us. So thank you. Did anyone have any questions, comments, or thoughts that they wanted to share with the group or ask Kylie?
Do you know any magic words that will get CGMs approved for nursing home residents? We have a type 1 in our nursing home who's hypoglycemic a lot, and it would be very nice. Apparently, the payers think that the nurses have nothing else to do but stick this poor woman.
I don't know about nursing home. Dr. Giordano, do you know?
So if you look up Medicaid, so I'm sure there's kind of a mix of Medicaid, Medicare, private pay. But if you look up Medicaid recommendations for CGM or Medicare recommendations for CGMs, it will give you the stipulations for each of those insurances that you can print out. And that's what I print, the prior authorization kind of request form for all the criteria that needs met. So for instance, like Medicaid patients must have like type 1, type 2, must meet certain age restrictions, must be compliant in their regimen. So you can look those up and print them out individually, which I think is helpful. It's just frustrating. I feel like endocrine clinics have a more streamlined process because our nurses, they're like trained on how to try to get CGMs authorized, but I feel really bad because I know, a lot of our colleagues in primary care and internal medicine reach out to us with this same question. And I think that insurance companies make it so challenging to obtain these things that it really requires nursing staff that is very in tune and adept with the different recommendations that the patient has to meet before they approve them. And so I don't really have a good way around that. I know that as long as I tell all physicians or people that ask that to just make sure if your patient is doing self-monitoring and testing of a frequency of 4 or more times per day for 3 months, that you make sure to put that in your note, because insurance companies definitely look at how frequently they're testing and how much they're injecting their insulin. So I think that is helpful to make sure you're documenting what's going on. But outside of that, I don't have any other specific tricks to get them covered. I will tell you that, like, for out of pocket, we talked about the Libre and the price changes, and it's different from differing pharmacies, but the most recent pricing that I've heard for that one particularly is about $65 for a month supply, which is 2 sensors. And then you used to have to buy the reader, but now with the app, that saves you about a $65 price for the reader itself. So I think that's one good piece of news, but it's still, $65 out of pocket per month is still very steep, for a lot of people, and that's unobtainable still.
I think Dr. Rexford, another thing too is if the patient is having hypoglycemia unawareness, like if they don't know they're going low, they're just catching it when they're doing finger sticks, I would definitely document that too, because that could help. Sometimes insurance companies will approve it for hypoglycemia unawareness.
Yeah, thanks. It just seems like nursing homes have a separate set of rules, and I think they may make them up as they go along, but
Thank you both so much for the feedback, and I definitely agree, Dr. Rexroad. It's always difficult in nursing homes. Any other questions, comments from the group? Jackie, I know you had maybe kind of a question earlier when we were doing intros. I didn't know if you wanted to ask anything. No pressure at all if you don't want to, but I know we have some time left, so I wanted to give you an opportunity to ask questions if you have any.
Well, it's just that they've just changed me from Metformin to Jordian. I'm taking both right now, half and half, because I had major gastric issues with Metformin, And everything's been going along good. Everything's starting to line up. My A1C was like 6, sometimes even in the 5s. My blood sugar was hanging around 140 when I would check it. Blood pressure was coming down. Everything was sliding into place. And then I got hit with what they said was plantar fasciitis in my foot. It was the most painful thing I have ever. I could have a baby before I'd have this again. I still can't walk very well. And I bought the expensive shoes. Didn't help. Do all the exercises that they've told me. My husband spends hours massaging my foot. And I'm still, after 3 weeks, I'm still in extreme pain. And I wrote my doctor a message on the portal, and she said to see a podiatrist, I might have to do surgery. And I just can't face up to having foot surgery. Sounded terrible. So then I got started thinking, is there any way that this is connected? I mean, I did some research online and I couldn't find anything about diabetes and plantar fasciitis. There was, the thing about sores on your feet, and you had to watch them to make sure they didn't get infected. There was all kinds of information about that. But today my foot, if anything, is worse, and it's hot. My foot is hot, but there's no open sores. Very swollen, but no open sores. So I'm at the end of my rope. I'm ready to go to the doctor, and I don't want to. I go to the doctor all the time. So what do you guys think?
Well, first and foremost, thank you so much for sharing that. It sounds incredibly difficult, and I don't blame you. It's difficult going to the doctors, and I know you said you've been going a lot, so it's just one more thing. But
eye doctors, kidney doctors, gastro doctors, the list is about this long. Medicine's this long.
Absolutely. Thank you for sharing that. I didn't know if any of the clinicians had any feedback or maybe some recommendations, advice for Jackie.
Hey, Jackie. I do think plantar fasciitis can be related to diabetes. We know that diabetes is overall related to inflammation, and diabetes in itself can attack the nerves and vascular centers of the body. So yeah, I mean, it definitely could be related. There are a lot of treatments that you can try for plantar fasciitis before considering a surgery. And some of those things are things like wearing a boot on your leg and immobilizing or stretching that fascia overnight. And you can order that yourself. It's something that you can do. And what it does is it flexes your foot upward at night. It's not the most comfortable thing. It's pretty bulky, but that flexes the fascia overnight so that when you wake up, it's not had a time to tense, because a lot of people with plantar fasciitis wake up with kind of crippling pain, and it's really difficult, especially in the morning. And I would certainly try doing that. And usually these things, if you don't get better in a week or two, it is important for you to understand that this is something that can take months, like 6 to 8 months to improve. So wearing a boot and being really consistent with it, and not letting your foot touch the floor without, wearing good cushioned shoes and wearing that boot every night. And then there are a lot of exercises and stretches that you can find on your own online to stretch out that fascia on your own at night. And I think those things will help. Certainly controlling your diabetes is always beneficial for any condition, whether it's acute or chronic. And you said your A1C was 6%. So, I mean, you're doing a great job of that. But as far as the plantar fasciitis goes, I mean, you can see a podiatrist, and that doesn't necessarily mean that you're going to be subjected to a surgery. You may get the same kind of spiel that I was just telling you: stretching, wearing the boot, controlling your sugars. Those are some of the most common things to help.
Well, the boot arrives today. I already ordered it.
There you go.
So
I would recommend. So
I've been doing the exercises, including one of these little roller.
And if you said you had an intolerance to metformin, I would say
Yeah,
if it ever causes, GI issues, we have some extended release versions that just break down in your gut slower. So that
that's what I was taking, was the extended release. And it didn't help. I was taking 4 a day, 2 in the morning and 2 and then at night of the 500s. And I don't know if that's what caused it or not, but I was having extensive diarrhea issues to the point till I wondered if I was going to be able to keep working. But when we cut it down and put me on the Jordan, then all of that stuff calmed down. Everything straightened out. I thought, oh wow, we finally hit the magic dose. Oh well, one more thing's got to happen. Well, at least I was able to cut it back by one doctor. But if I add the podiatrist back, but I will definitely remember that you said it could take a long time to heal. So that makes me feel better anyway. I was kind of thinking 2.5, 3 weeks, it ought to be okay.
Oh, no. It's going to take many months. I'd anticipate at least 6 to 8, maybe longer.
And I got a walking pole too to keep me from falling. That seemed to be the most troubling thing too. I would be even just standing and all of a sudden I would, do the sideways trot.
Well, Jackie, it sounds like you're taking all the correct measures and doing all the right things. So if you need us to be there to help you boost your mood and keep you positive, we're here for you for that aspect.
Thank you. I appreciate that. I'm glad to know that I'm doing all that. I was feeling kind of morally guilty about not going to a doctor. I mean, you hear it all the time. Don't not go to the doctor. It's not the right thing to do, blah, blah, blah. But just.
I know Dr. Giordano mentioned some shoe insoles. I've actually seen in some drugstores, they sell Dr. Scholl's insoles and they're specifically for this. So
Right.
I wonder if maybe those would help. I'm sure you're already on it, but I noticed.
Actually, I didn't like the insoles, so I decided to spend money and buy the expensive shoes. Believe it or not, these things cost $165. And they have a 45-day break-in factor. So you have to wear them for like specified amounts of time for 45 days. Well, I'm up to half a day. So in the morning, my feet do pretty good, but in the evening, in the afternoon and night, oh, it's just terrible. But I think I'm finally getting the right spate of exercises to do and stuff like that. So
That's good to
I'm
hear.
doing all I can do other than try to go to a doctor. Although those steroid shots that they, I took those when I had knee surgery years and years and years ago. That's pretty good, get a shot and not hurt for 6 months, but it always comes back.
Thank you so much for sharing that.
Oh, you're welcome. Thanks for listening. And
Absolutely. Thank you, Dr. Giordano, for the feedback and everything. Did anyone have any other questions or thoughts before we go into the announcements for the end of the session? Alrighty, well, big shout out to both Dr. Rexrode and Kylene for the awesome echo presentation. My only announcement is that our next session will be on January 12th. And Dr. Giordano will be presenting on PCOS, so keep an eye out for that reminder. Elizabeth and I just want to wish you all a very happy holidays, happy new year, and we appreciate each and every one of you. And we look forward to starting the new year with you all. So thank you all so much, and we'll see you guys next time. Take care.
Happy holidays.
Bye.